Good afternoon. It's Angela Wiles, DNP candidate at Murrary State University, and we're going to be talking about insomnia today, assessment, treatment, first-line treatments, just elevating your understanding and treatment proficiency. So what exactly is insomnia? This I've got on the next 3 slides is the official diagnostic criteria from the DSM-5, which is the Bible of Psychiatry. And I'm not going to read these slides to you, but basically it's outlining all the criteria that must be met to have an official diagnosis of insomnia. It's related to patients having difficulty getting to sleep, staying asleep, and also patients who report early nighttime awakenings. So difficulty falling asleep, some people fall asleep fine and wake up multiple times during the night. Some have both. Some get to sleep fine, stay asleep for a few hours, and wake around 3 or 4 a.m. in the morning. So that is problematic. Also, as part of the diagnostic criteria, they must have some type of impairment. It must occur at least 3 nights a week for 3 months, not be attributed to a substance or any other sleep disorders such as sleep apnea, and we'll talk about that, and other mental and medical conditions do not explain the reason for the insomnia. There's 3 specifiers related to insomnia. Episodic, which is a shorter duration. Instead of that 3 months, they have it at least a month, which is a long time, but not the 3 month for the diagnostic criteria. Some people have persistent insomnia, which is 3 months or longer. And then recurrent, which is someone who's had a episode of insomnia, it's resolved, and then it's come back within a year. So insomnia is fairly common. As many as 1 in 3 adults have symptoms of insomnia, but only about 10% meet the criteria, which is very strict for insomnia disorder. So insomnia has a huge impact on our health, a huge impact on the health system, on the resources. You can see these top 6 conditions are fairly heavy medical conditions that insomnia increases the risk of. I can only imagine the financial impact of these 6 conditions, much less the human suffering impact of these 6 conditions that insomnia contributes to. We also have very practical difficulties related to insomnia in the workplace. Causes a lot of people to miss work. A lot of people call in sick because they just didn't sleep at all the night before. And even when they do make it to work, their productivity suffers. There's an increased risk of accidents in the workplace. Just imagine that assembly line worker that has not slept the night before, or has not slept not slept well for days. They're increased risk for accidents. And overall, patients who suffer with insomnia report no workplace satisfaction. They're not happy in their jobs. So a lot of workplace effects of insomnia there. This slide shows the financial impact of insomnia. It's picked 5 of the larger countries: United States, Germany, Canada, the UK, and Japan. And just those 5 countries alone, the financial impact is losses of over $680 billion, and that's annually. So how do we assess insomnia? You know, unlike a lot of conditions in medicine, there's no lab test, there's no imaging. We're relying fairly commonly on patient report. What are they complaining of? They just say they can't sleep, right? Well, what exactly does that mean? What questions do we need to be asking? We need to be talking about their sleep consistency. Do they go to bed at 7 o'clock one night and 1 a.m. the next night and 10 the next night? What time are they getting up? Do they have a routine? Do they sleep till noon? Why are they waking up? Do they have chronic pain? Do they have nocturia? Are they going to the bathroom a lot? I get that report fairly commonly, both of those two. They've had shoulder surgery, back surgery, um, and that's the reason they're waking up. It's not a true insomnia. And what are their expectations? Ask that question. What would a perfect night's sleep look like for you? Going to bed at 10 and waking up till 6. What does that look like for your situation? Really involve the patient in these conversations. This slide, I was really shocked when I ran across the information when I was doing research for my project during this program, that racial and ethnic minorities are much higher to report severe insomnia. But as you see in that second piece, they're a lot significantly less likely to have an FDA-approved insomnia medication on board. So they have a lot more severe symptoms, but less likely to have an FDA-approved medication. So something that we need to keep in mind, and in those health disparities, and really this is something that should not be happening, that we need to really keep at the top of our mind and be on top of and really be aware of. This is called Insomnia Severity Index. It is a screener that we can use. It's 5 questions. It's really 7 questions. The first one has 3 questions, but it basically follows to the letter that diagnostic criteria that we talked about at the first. Are you having trouble falling asleep, staying asleep, waking up too early? How satisfied are you with your sleep pattern? How does it interfere with your daily life? So you notice that it kind of goes right along in plain patient language, that criteria. So it really helps with a true diagnosis of insomnia. And over to the right there, it shows the scoring and the interpretation. So this is one thing that, and we'll talk about this in a sec, about how not a lot of people use these. They go solely on patient report. And one good thing about this, if somebody comes in and they scored like a 25 the first time that they see you for sleep problems, give it to them again in 3 or 4 months after you've made some changes, after you've, whatever your intervention is, and then you can see the scores improve, or do they stay the same? Do we need to do something different? A lot of people think, I'm not getting any better. They say, this is not better. Then you can pull out your initial assessment and show them, look, you were at a 25, now we're at a 15. Although it's not perfect, we're definitely moving in the right direction. So it's a lot of good information there, and it really helps you to remember a lot of the questions that sometimes we forget to ask. This is a 2-week sleep diary. You see this used a lot by sleep specialists. It really will help pinpoint where some of the issues are. You have the patient fill it out for 2 weeks. They mark down when they take their medication, when they drink caffeine or alcohol, when they exercise, what time they go to bed, what time they wake up, how many nighttime awakenings are they having. So once that whole grid is filled out for a 2-week period, you can really start to identify some patterns of problematic patterns that you can help to correct. So there's lots of causes for sleep difficulties, right? There's people that come in and complain and say they have insomnia. Well, we really don't need to just throw medication at that. We need to really give a good assessment and ask all the right questions. Patients don't always put 2 and 2 together. I've had patients come in reporting sleep problems that were on high doses of steroids for another medical condition, and no one ever told them that the steroids might keep them awake at night. So medications, stimulants, a lot of patients on stimulants nowadays. So And a lot of them have found out the hard way, if they wake up late and take them at 11 or 12 o'clock, they're going to have a problem sleeping that night. So ask those questions. Pain is another big one that you see, um, that causes patients to have sleep problems. Substances, whether that be illegal substances, cocaine, methamphetamine, or just caffeine. Caffeine, you've got excessive energy drink usage. You've got lots of coffee. Some patients drink multiple pots of coffee at night. So lots of other issues. They're exercising too late in the evening, taking a run after their after dinner. Or I see this one quite a lot too, shift work disorder. Patients who have a natural circadian rhythm of being that early bird, they're forced to work a third shift. Lots of medical staff working shifts that do not coincide with their natural circadian rhythm. Differential diagnosis here: obstructive sleep apnea, narcolepsy, two um, big ones that we want to make sure that it's not truly insomnia that's causing patients difficulty. It could be other sleep disorders. So we want to keep that in mind. I've got some information there on sleep apnea, the mild, moderate, and severe, that AHI, that apnea-hypopnea index, or the number of times an individual is not breathing during the night or stops breathing, and that actually wakes them up. So they're technically sleeping, but they're not getting good, sound, restorative sleep. Narcolepsy, patients that fall asleep during the middle of the day. There's another assessment tool called the Epworth Sleepiness Scale that's used quite a bit, and it assesses the likelihood of these individuals falling asleep in normal everyday activities, sitting at their desk, sitting at a red light, things to that nature. So if you hear patients complain of those things, let that narcolepsy kind of go off in your mind and get them to a sleep specialist to get that evaluated. Pharmacological agents for insomnia. Of course, there's lots of them out there. Over-the-counter agents, the Z-Quils, the Benadryls, the Unisom, all of those, melatonin. A lot of patients, once they get to you, they've already tried and failed all of those. There's the sedative hypnotics, the Ambiens, the Belsomras, Lunestas that we have, benzodiazepines. Surprisingly, you still see those prescribed for insomnia. And then the off-label options, the trazodone, which is an SSRI, antipsychotics, you see Seroquel or quetiapine prescribed commonly for sleep. Pros and cons of those pharmacological agents. Pros, cons. Pros, they definitely work. They're effective. People will get a good night's sleep. However, on the flip side of that, you have people that, hey, I slept the night before, but you know what? I couldn't hardly function the next day. I was so sleepy, and they describe it as feeling hungover the next day. So the treatment is actually causing just as much or more problems than the insomnia itself. Side effects. Those we just worry about those safety issues with all patients, but especially with older patients. The pharmacological agents can cause an increased risk for falls. So in older populations, we all know that that's never good. You have a fracture, and that just goes downhill. So lots of risk and side effects with the pharmacological agents for insomnia. Lots of options for interventions for helping people that are having difficulty sleeping. Exercise is a big one, yoga, relaxation. There's lots of videos on YouTube that are meditation and relaxation based. There's sleep podcasts. If you're not familiar with those, highly recommend them. It was recommended to me by a sleep specialist that I worked for years ago. And I thought he was joking at the time when he recommended that to me, and I really have used it fairly consistently ever since. So if you've never heard of those, give them a try on the podcast. Wherever you get your podcast, you can find sleep podcasts that really, really work. The military sleep method is like a progressive deep breathing and muscle relaxation technique that's very effective. And also CBTI that we will talk more in depth about later. As um, part of my project, I surveyed a local advanced practice provider association here in Middle Tennessee. They have multiple specialties, all practicing APRNs. Um, and these are the questions that I presented to them about how many patients do you treat, and there were several um, that saw several insomnia patients, which is very common in my practice. How do you rate your familiarity and knowledge of treating insomnia? This was a big one for me because you see there on the somewhat familiar and not so familiar bars, you add those two together, you're over 80% of the respondents of this survey that are not very confident in their ability to assess and treat insomnia. So that was a big one for me. Um, Most people agree that majority of insomnia is caused by poor sleep hygiene, other modifiable factors. It can also be genetic. So diagnostic screeners, this was also a big eye-opener for me. Diagnostic screener use, you see there rarely and never. Add those two together, you're pushing 85% of the respondents never use a diagnostic screener like we looked at earlier with the insomnia severity index. Non-pharmacological intervention is first-line treatments. Most people are using those, not going straight to a prescription or medication, trying to use some of those practical interventions. Not using a lot of Ambien, Lunesta, sedatives, hypnotics as first-line treatments. Treatment and reserving those for treatment-resistant cases. Non-controlled medication is first line. The trazodones, doxepins, Seroquels usually. And then familiarity with CBTI and using or referring patients. This was also a big one. Disagree and strongly disagree. There you can see that that is about 60% of the respondents was not familiar with it nor used it or referred patients for it. So what are some of the things that I learned from this survey is a lot of inconsistencies. Whether that be in assessment, treatment, first line, choices, a lot of inconsistencies among the providers. Infrequent use of diagnostic screeners, almost none. And then just a lack of awareness of CBTI in general. Just not a lot of people were familiar with what it was. Where do I go to have this for my patients? Just a lot of infamiliarity. So what does the evidence show? Evidence shows that CBTI is equally as effective as a medication for insomnia. You see a lot of patients in practice. For those of you that are already practicing, I know in my practice, a lot of patients feel like that's the answer, right? Medication is the only answer, and that's not necessarily the case, especially as insomnia. CBTI is recommended as first-line treatment, and virtual options were equally as effective as face-to-face, which is a good thing as far as availability is concerned. So evidence also shows that pharmacological agents not recommended as a long-term option, short-term only. You see a lot of it in practice, patients that have been on sedatives, hypnotics for years, but not in the evidence is what that is a recommendation. So should be reserved as an adjunct treatment. And those treated with pharmacological agents alone quickly return to their baseline insomnia. They were back to square one as soon as that medication was discontinued. So cognitive behavioral therapy for insomnia, what is it? Like, it's a 6 to 8 session treatment consisting of sleep restriction therapy and stimulus control therapy. You hear of those people. I'm guilty. I'm sure we all are. Of, oh, I've got to make up for that sleep. I only got 4 hours last night. I was studying for a test. I was working on a project. I only got 4 hours. I need to get more tonight to make up for it. And that's just not effective. So a lot of people guilty of that. And also that stimulus control. Lying down when you feel sleepy, getting up when you're not sleepy. Don't lay in bed for an hour just trying to go to sleep. I hear people say that all the time. I was laying in bed for 2 hours trying to go to sleep. Not effective at all. Sleep hygiene alone, research shows that minimal improvement, right? There are things that patients are doing that are contributing to their poor sleep quality, but just that by itself alone is very not effective at all. But those things that we need to recommend to patients, you know, caffeine, alcohol use before bed, not napping, getting lots of physical activity, wearing our body out, right? Like, our mind is tired, but our body is not tired. So lots of recommendations that came down from this project, you know, just addressing those treatment gaps, those inconsistencies. We were kind of all over the place of what we were doing. Were we following the evidence? Were we not? Just having a more consistent, you know, using diagnostic screeners that helps streamline our care, helps us not to forget those areas that we need to ask about. Facilitating peer collaboration. I was lucky enough to work for a sleep specialist for many years, and I have him on speed dial, right? I can call and ask if I've got a difficult case and get them in with a sleep specialist. So having that collaboration with other members of the healthcare team, you know, promote patient-centered care, involve patients in their care. They're much more successful. So what can you do to improve assessment? So number one, those diagnostic screeners, the ISI, 2-week sleep diary, Epworth sleepiness scale, any of those are great just to show improvement. We can show baseline. We can prove that what we're doing is working. Or is it not working and we need to go further? We need to see a specialist. You know, you can educate your patients. Like I said earlier, a lot of patients think medication is the only option that they have, and that's just simply not true. And a lot don't realize the risk that the pharmacological agents put them under. And also to promote patient-centered care. Involve the patient in the decision-making. They're lots more likely to adhere to a treatment plan that they help develop. They'll be more successful. And encourage those lifestyle changes. I've got a couple of case studies here that I just went over in the lecture that I did at the university. And these are actual patients of mine. 69-year-old female, reported difficulty sleeping. You hear that a lot. How's your sleep? Oh, it's terrible. And you can't just let that be all that you ask, right? I delved into it, sort of, we really sat down and talked about it, and long story short, this patient's expectation was to sleep from 6 p.m. to 6 a.m. And so she had a very unrealistic expectation of what sleep was like. So she reported it as terrible because she was not sleeping 6 p to 6 a like she expected. 34-year-old female reporting an inability to sleep. This is an African-American mom of a 6-year-old autistic child that she reported poor sleep. Well, we talked about it. I asked her tons of questions, found out that she was actually drinking an energy drink at 10 p.m. at night. because she was fearful that she would fall asleep while her autistic son was still awake and that he would elope or would not be safe there. So she was trying to stay awake until her son fell asleep. So we had a lot of education on this patient and the previous patient. So lots of education.